All right, so today we're going to go over about 10 unknowns, and we're going to approach this by looking at where the pathology is. Particularly, these are kind of grouped into epidermal pathology entities, and so vesiculobullous or related entities. That's kind of the unifying theme here. Now, one of the problems of just doing H&E unknowns for vesiculobullous entities are that you need to have a little bit of additional information to truly make the diagnosis in many cases. But if you're given a list of choices, you can rule out the other answer choices because you know that it's not going to present with that type of epidermal pathology, then you'll be able to at least select the answer as long as they don't put two that are going to be fair. And they won't do that on the test, but in real life, sometimes you just have to get the clinical information to be able to actually make the diagnosis. So that's actually, that concept is pretty well illustrated here with the first case. So this is looks to be a punch biopsy, and you can see that the epidermis appears to lack a stratum corneum. It's a little bit acanthotic, a little bit spongiotic, but it doesn't really have a nice stratum corneum on it. So if you can think about clinically what this would correspond to. Now, some people might think, are you on a mucosal surface or something like that? But here you have a hair follicle, so you know you're not on a mucosal surface. So looking at the epidermis here and knowing that there seems to be a lack of granular layer and a lack of stratum corneum, you might be thinking, oh, I've seen a lack of a granular layer before in psoriasis, for example. So that might jump into your mind. But usually with classic psoriasis, you'll not only find regular psoriasiform hyperplasia, but you'll also find a hyperortho hyperperikeratosis with abundant neutrophils in the stratum corneum and untreated psoriasis. And so if someone tells you the clinical that this patient seemed to be forming these very fine, almost cornflake-like type lesions on the skin, where you have some superficial scaling of the skin and some very like almost little blisters that barely stay alive before they rupture, then you'll start to probably think about the correct diagnosis. So on direct immunofluorescence, let's say you took a direct immunofluorescence sample perilesionally to this lesional sample, and on the direct immunofluorescence, you got some IgG pattern that was highlighting within the that's in between the interkeratinocyte or interepidermal region in the more superficial aspects of the epidermis. So what's your diagnosis? So if you're thinking pemphigus foliaceus, you're correct. Now, if you were just given this picture and you were not given any clinical information and you were not given any direct immunofluorescence information, then what you would actually have to consider is a staph scalded skin syndrome, which can look exactly like this. Sometimes even Bolus Pentagoid can look like this, but you're going to usually see more bacterial organisms here in the bulla space, because Bolus Pentagoid, you're going to actually have a lot of bacteria. But in staph scalded skin, unfortunately, you don't have that much bacteria. In fact, it's a toxin mediated process, and the toxin actually inhibits desmoglein 1. So pemphigus foliaceus is essentially where the desmoglein 1 is being destroyed by antibodies binding there, and essentially an immune mediated process in which the autoantibodies against desmoglein 1 are causing a lack of structural integrity at this level here at the superficial epidermis. And so there's plenty of desmoglein 3 down here, and that can kind of keep the structural integrity. Even though desmoglein 1 is being attacked, desmoglein 3 is still here at the lower parts of the epidermis. So it keeps most of the epidermis intact. So that's pemphigus foliaceus. Number 2. So here you see a punch biopsy. You notice this kind of bolus cavity already to the right. You go in higher power, you start to notice that the keratinocytes are almost forming a single layer in much of it here in the classic examples. And they're kind of sticking up a little bit, and that people call that a tombstoning pattern here. So with the buzzwords, you're already probably jumping to the diagnosis. But if I gave you the clinical that there's a couple of clinicals that might confuse you here. So if someone gave you a clinical of these forming flaccid blisters, many of them in the mouth, but also on the body, versus a clinical of macerated looking plaques underneath the intertriginous areas, such as the axilla, and you might start debating between 2 different diagnoses. So let's say that you also did a DIF on this, and the DIF showed positive IgG pattern at the deeper aspects, pretty diffusely, but also concentrating at the deeper aspects of the epidermis in an interkeratinocyte staining pattern. So then that will tell you that it's pemphigus vulgaris. And pemphigus vulgaris is an anti-desmoglein 3 mediated process. It can be both anti-desmoglein 1 and anti-desmoglein 3, depending on what type of variant you have. And so here, it's basically you don't have enough desmoglein 1 to compensate down in the bottom layers for the lack of desmoglein 3. And so that's why you get this disruption of the epidermal integrity down here at the bottom near the basal layer. Now, the keratinocytes still have all the other things that they need, such as type 7 collagen still working here. They've got Bolus Pentagoid antigen still working here. They got a lot of things still here. And so that's why these basal layer keratinocytes are still adhering very well, because they have all those other proteins that are going to allow them to anchor down to the dermis, but they don't have the critical protein desmoglein 3 to help keep them stuck together right here. That's the fascinating thing about cutaneous biology, is that we figured out a lot of the critical proteins that are important in each layer. And then when you have an autoantibody attacking one particular aspect of that architecture, then you actually will see in real life what's happening. And so it's just really nice to appreciate the link between the structural integrity proteins, autoimmune bullous disease itself and how it presents, and then seeing on derm path the evidence of that. So this is pemphigus vulgaris. Moving on. All right, so you see a punch biopsy. The defect mostly seems to be, actually, your eyes probably jump to this area here where it looks very similar to the last example. You have some areas that look like tombstoning. The keratinocytes are definitely breaking apart. And you can see over here that the keratinocytes are breaking apart at different levels. So you've got near the basal layer, you've got close to the granular layer, all kind of throughout all layers of the epidermis here, as you can see. So this is a type of pattern where you could probably at least label this acantholysis. And when you see acantholysis, you should be thinking, again, about the previous entity, pemphigus vulgaris, but when you see acantholysis like this and you don't see a lot of dyskeratosis, this pattern is called a dilapidated brick wall. And so again, I'm throwing out these buzzwords for you. If you're taking the exam, no one's going to actually tell you these buzzwords. So it's a little bit easier for you to jump to the diagnosis here. But I'm sure that you probably had in your mind, when I said acantholysis, you probably recognize acantholysis. If you've got the dilapidated brick wall appearance, you need to be thinking about Haley-Haley disease. And so Haley-Haley disease is more often going to show acantholysis without much dyskeratosis. And that's in contrast to Derriere disease, where you have a lot of acantholysis and a lot of dyskeratosis. So the clinical will be that these patients have macerated plaques under the intertriginous areas, the bilateral axilla. They're kind of wet and macerated, and it's kind of a lifelong problem that they have because they have a genetic defect in ATP2C1, which is a calcium transporter. It helps with calcium homeostasis within the cell. And they like to ask on exams sometimes, at least the factoid of calcium transporter being located in the Golgi apparatus in Haley-Haley disease. That defect, it's lacking there in the Golgi apparatus. But the other calcium pump, which is called ATP2A2, and that's the one that's defective in Haley-Haley, or in Derriere, rather, that's still present in the endoplasmic reticulum in this case of Haley-Haley, right? So it goes to show you that if one calcium pump is messed up, then you lose the calcium homeostasis and you get at least a form of acantholysis. So the ATP2C1 is mutated in Haley-Haley here, and it results in this acantholysis, and it's a dilapidated brick wall appearance, and it doesn't have much dyskeratosis. So the other thing that will help you is if you don't see definitive hair follicle involvement that supports Haley-Haley. This doesn't have a ton of hair follicles to look at here. So if they put pemphigus vulgaris and Haley-Haley on the differential, or both on the answer choice, it would be pretty difficult unless they told you that there was a direct immunofluorescence done and it was negative. So Haley-Haley is not an autoimmune bullous disease. It's actually due to a defect in the calcium transporter. So the DIF should be negative, okay? All right, number 4, I'll give you a chance to decide what type of defect this is here. All right, so you may notice that there seems to be a clean subepidermal bulla here. And when you identify subepidermal bulla, the next key question is what? What is the main component in the blister cavity? And so looks like this was scanned at 20x, so it's actually a little bit harder to get in to the blister infiltrate here, but I hope you can appreciate these bright red to pink granules in many of these cells. And so this has a healthy amount of eosinophils. So subepidermal blister with abundant eosinophils, you can think about Bolus Pentagoid. And so this is classic for Bolus Pentagoid. It's, if you sign this out without a DIF, you could say consistent with Bolus Pentagoid if that's what the clinical was. But of course, you want to get a perilesional DIF that demonstrates dense IgG and C3 along the basement membrane. That's going to give you your diagnosis of Bolus Pemphigoid. And you could think about other entities here. If you had a large bulla with a lot of eosinophils and you had an even dense wedge-shaped infiltrate where the inflammation was going all the way down, you could also entertain the diagnosis of a bullous arthropod, which would have a negative DIF. Remember the defects in Bolus Pemphigoid. Mainly, it can be due to both Bolus Pemphigoid antigen 1 and 2, but Bolus Pemphigoid antigen 2 is the main functional defect. And you can have, the other name for that is BP180 or collagen 17. So depending on, which test question writer just prefers which name, or whoever wants you to know which name more than the others, they could all be asked and you should know all of them. So BPAG2, Bolus or BP180 and collagen 17 are the 3 names that major protein goes by. And it's located a little bit higher than collagen 4 and collagen 7. So if there's an autoantibody against Bolus Pemphigoid, the antibody is going to attach higher than collagen 7. And the bulla that's going to form is higher than collagen 7, okay? So if you were to do a salt split test to figure out, is it Bolus Pentagoid, which is due to anti-collagen 17, or is it Epidermolysis bullosa acquisita, which is due to collagen 7, then what you're going to do is you're going to put the skin in 1 molar sodium chloride. That's going to split. It's actually going to cause a split of the skin, and that splitting of the skin is going to allow for the Bolus pemphigoid antigen. Okay, we're talking about just splitting that skin with the sodium chloride. It's going to cause that Bolus pemphigoid antigen to be located higher in the roof of the blister, and it's going to cause the collagen 7 to be located lower, okay, on the floor of that salt split skin, okay? So then what you're going to do, and again, you're looking at, you're doing salt split skin on something that doesn't have a bulla, right? You're doing the salt split skin on something that has not formed a bulla. So that's going to be a perilesional piece of skin. But what ends up happening is when you actually do the DIF on that, you're going to find that the immunoreactants will go to the roof on Bolus pemphigoid because, as I said, the split causes that Bolus pemphigoid antigen to go higher. So you would actually see it decorating the roof of the blister. And if it were Epidermolysis bullosa acquisita, you would see it decorating the floor of the blister. Clinically, these are tense. They're tense blisters. And so in contrast to pemphigus vulgaris or pemphigus foliaceus, you can see why these are more tense. It's easier to hold a lot more blister fluid there. Okay, so that's Bolus pemphigoid. Wordy dyskeratoma is the next one. So I put this here because this is not Darier's, but it can look very similar to Darier's. So I mentioned that the acantholysis and the dyskeratosis is a prominent feature of Darier's disease as opposed to acantholysis without a lot of dyskeratosis. In dyskeratosis, you see it's more, you got these circular pink spheres that are forming keratin way too quickly, or they're forming that dead keratin, not dead keratin, but they're forming as if they're already located way up in the near the or past the granular layer. So that's a dyskeratosis. So they're forming core rons, which are these circular dyskeratotic cells, or core grains, which are the more flat ones. And when you see this pattern of acantholysis and dyskeratosis, you can think about if it's an actual rash on the person or it's a multi-location lesional skin disease, then you can think about Darier's disease, which is a mutation in ATP2A2. Now, interestingly, if this is just a single lesion that's located on the skin and it's kind of an endophytic cup-shaped lesion like this, warty dyskeratoma is the diagnosis. So both of these have been found, both Darier and warty dyskeratoma have been found to show defects in ATP2A2. So just know the pattern of acantholytic dyskeratosis to give you a proper differential diagnosis. You can also have acantholytic dyskeratosis in Grover's disease, but with Grover's disease or transient acantholytic dermatosis, it can be more of a Haley appearing variant or more of a Darier appearing variant, but typically these are really small papules. So if you see small papules with acantholytic dyskeratosis or even just a bunch of acantholysis without dyskeratosis, it still could all be in line with a Grover's, but the size of each individual area that's involved is not very large. And clinically, it's just not, it's not as striking as Darier's or as Haley. All right, moving on. So here you see an intraepidermal pathologic process. It looks almost like keratinocytes are blown apart here. And so if you've seen multiple examples of this, you can actually get the diagnosis right away. You're seeing collections of nuclei here forming multinucleated giant cells. You're seeing some areas where the chromatin seems to be going dark to a darker rim on the outside. And that's kind of like a marginization effect. And you can even see that the nuclei are kind of smashing together and molding together. So we've got molding, we have margination, and we have multinucleation, the 3 M's of herpes virus infection of the skin. So you have to be able to recognize this on H&E. It's one of the more beautiful diagnoses on H&E because it's just so striking in many cases, depending on how much viral load is here in the herpes vesicle and what evolution it is as far as the pathology goes. So be sure to look at many examples of herpes virus infection because it's definitely one that they can definitely put on the boards just as a recognition with no clinical information whatsoever. And I'm just scrolling around here to actually show you the different stages of epidermal necrosis. So obviously these cells died much longer ago because they're much more eosinophilic in nature, homogeneously. And many of them actually lack nuclei at this point. You can have some overlying neutrophilic inflammation too. It's kind of like forming a little bit of a pustule with the acute inflammation healing program starting to try to recreate the skin barrier again. Anytime you have some kind of superficial ulceration, you can have what looks to be leukocytoclasis, maybe even some areas that look like leukocytoclastic vasculitis within the dermis here. And so it can be a little bit tricky. You might be thinking, oh, is there a leukocytoclastic vasculitis happening here? But as I like to remind the residents, anytime you have significant epidermal ulceration and erosion, I mean, this is technically an ulceration because it gets down to the dermis here, but then you can have a secondary kind of leukocytoclastic inflammatory process that looks exactly like leukocytoclastic vasculitis. So they shouldn't put anything about a bullous leukocytoclastic vasculitis in here if they just gave you this type of picture, but seeing the actual multinucleated giant cells, the viral infected cells, and how it changes the nuclear contours, that's going to be key for you to make the diagnosis. So that's herpes. Now here's something that looked clinically like herpes, and that's where it gets its name from. So you see reticular degeneration, where the epidermis has been kind of the detachment between the epidermis and the dermis is obliterated here. As you scroll along the epidermis, you'll start to see areas that are going to give you that snapshot recognition pattern for the diagnosis, which is this kind of neutrophilic microabscess that's collecting in the dermal papilla. And so this is where the pathology starts, right? This is where you're having some type of autoimmune granular deposition of IgA, and that's what you're going to find on the DIF. And as it progresses and as you have detachment, you're going to have more of a reticular degeneration like this. So depending on how long the epidermis has been detached, it's going to start dying off here. And you're going to have, you can even have a little bit of lymphocytic inflammation here, neutrophilic inflammation. It's going to cause degeneration and death of the keratinocytes eventually. But even just the detachment, how long it's been detached, is going to cause necrosis. As you see, it's just starting to die off here. But the way you're going to get the clean diagnosis is by finding those neutrophilic microabscesses over here on H&E. And so the diagnosis is dermatitis herpetiformis. The IgA-based antibodies are attacking the antigen transglutaminase. These patients often have a gluten sensitivity. And on DIF, as I said, perilesionally, you're going to get more of a granular deposition of IgA. And after that granular deposition, you'll start to have, as you approach more of the center of the lesional skin, you'll have these neutrophilic microabscesses. Now, it can clinically look a lot like herpes and blisters, but the location are typically the extensor surfaces, as classic Kodachromes will show you, where they're showing the patient showing you the back of their arms or their knees. So this is a dermatitis herpetiformis. Now, something that looks very similar to that and can actually look pretty identical depending on how evolved it is the next case. And so this patient was given vancomycin and then shortly thereafter developed large bulla here. And you can see these kind of pseudo neutrophilic microabscesses. Actually, they are neutrophilic microabscesses in a way, but it's kind of more contiguous in terms of the way that the skin is lifting off here. So in some sections, it's pretty indistinguishable from dermatitis herpetiformis, but I hope you can appreciate how confluent the neutrophilic inflammation is along the dermal epidermal junction. And if you were to do a DIF on this, you would find linear IgA pattern. And so that's your diagnosis, linear IgA bullous dermatosis. And the key is to know that vancomycin often stimulates this production of antibodies against collagen 17 subset. It's a smaller, it's like a 90 kilodalton portion of the collagen 17, but it's a completely different mechanism in which the IgA binds to it, and you've got this neutrophilic infiltrate. Now, you can often find a bunch of eosinophils in the mix too, so it's kind of keeping that drug-induced flavor, as I would think about it. So the eosinophils remind you, because you'll see more eosinophils in this entity probably than you will see in dermatitis herpetiformis, but sometimes you can see a lot of eosinophils in DH as well, so you wouldn't want to rely on that completely. In fact, if they put DH and linear IgA bullous on the answer choices and they didn't give you a DIF pattern, then it would be tough to definitively say. But given the confluent nature of these neutrophilic inflammatory infiltrates with the eosinophils, I would favor a linear IgA bullous dermatosis, but in real life, you definitely need more evidence from the DIF to show you that it's a linear IgA deposition along the basement membrane. And you can see that this is it's like a lesion that's just starting to form here, because as you go to the side, that's where you're getting a bulla. So they took the biopsy right on the edge of the blister, but they were really interested in this part here. And again, if you took a lesional biopsy and it was very central to the bulla and this skin had been detached for quite some time, you're going to find a lot of reticular degeneration and cell death within this detached epithelium. So this is pretty freshly detached epithelium, because the keratinocytes look very healthy and viable still in many ways relative to other examples that we've seen. So that is linear IgA bullous dermatosis. And you should contrast that to dermatitis herpetiformis. Okay, so again, without a lot of clinical information, you just can see a subepidermal bulla on this. If you go on higher power, though, you're not going to see a ton of inflammation here. So you should be thinking more along of a differential of what's going to include a posse inflammatory bulla. You can have a posse inflammatory Bolus Pentagoid. So you might find occasional eosinophils, so you may not know, is this Bolus Pentagoid or is this another entity? So as I mentioned previously, if the patient has an autoantibody against type 17 collagen, or an autoantibody against the other names of type 17 collagen, which is BPAG2 or BP180, it can form a subepidermal blister. If they have an autoantibody against type 7 collagen, such as an epidermolysis bullosa acquisita, they can also form a subepidermal blister. How do you tell if those are both in your clinical differential diagnosis and you get a subepidermal blister like this? You do a perilesional DIF and you see IgG and C3 linearly along the basement membrane. Can you say that it's not EBA? Can you say that it's not Bolus Pentagoid? No, it could be either of those. So you need to do a salt split scan and look to see where the immunoreactants are localizing. So if it localizes on salt. So if you go perilesional and do a salt split skin, over here, you get the salt split skin on this, you're going to find that the EBA, which is this diagnosis, the immunoreactants are going to go to the floor of the salt split skin, because salt split splits it to where the collagen 7, which is attacked in EBA, stays on the floor of the generated bulla. So in real life, though, over here, you know, the collagen 7 was attacked already. This is not salt split skin. This is pathologic split skin. So this is going to have type 7 collagen already attacked. And so it's gone here, basically. It's degenerated. It's not around, right? The immunoreactants, you don't know exactly where it is at this point. It could be somewhere, some here and some here. It's unclear. But if you do perilesional DIF, and you get a salt split skin, then you'll be able to localize. So if immunoreactant goes to the roof, you're going to think Bolus Pentagoid. If it goes to the floor, you're going to think epidermolysis bullosa acquisita. And that's what this was clinically, epidermolysis bullosa acquisita. Now, this can look very similar to the real genetic defects that lead to epidermolysis bullosa. So there's different kinds, and we can get into that in a different lecture, but dystrophic epidermolysis bullosa is the variant of epidermolysis bullosa in which collagen 7 is defective. And so you can have a subepidermal blister forming at the same plane here. But in dystrophic EB, they don't have an autoantibody against the collagen 7. They just lack the collagen 7. There has been some suggestion that if EB patients are introduced to cells that contain type 7 collagen, that they may or may not be able to produce autoantibodies against collagen 7 because they've never seen collagen 7 before. But that's interestingly not the case in many different types of clinical trials. So it's just very interesting to think about. All right, so that's epidermolysis bullosa acquisita, and you should understand the role of salt split skin in helping to differentiate between Bolus Pentagoid, the variant of posse inflammatory. Now, if you were just given the choice without DIF information, you should go with an EBA here because it doesn't have a lot of eosinophils, and so that makes you think that it's not the classic Bolus Pentagoid that they would show you on an exam. And the last example is another subepidermal blister, subepidermal bulla here, and it's got areas of significant neutrophilic inflammation. So the other differential diagnosis for neutrophilic inflammation without a lot of eosinophils, forming a subepidermal bulla, you should be thinking about Bolus lupus. Bolus lupus, interestingly, also has autoimmune activity against collagen 7. And so the two that you need to remember, autoimmune activity against collagen 7, are EBA, which we just discussed, and Bolus lupus. Now, if you were to do a DIF on this skin, on the lesional skin, you should find more of a linear band classically, but not always, unfortunately. So you have to correlate clinically the patient's condition. Do they have systemic lupus? Do they have evidence of previous cutaneous lupus? Do they have positive ANA? Those types of questions. Are they photosensitive? Classically, Bolus lupus is not going to contain a lot of eosinophils, but it will contain lymphocytes, neutrophils, and a subepidermal blister. So this example is impossible to get right 100% unless you're given answer choices that absolutely would not fit, and they only left Bolus lupus as the remaining only one that made sense because it's subepidermal. You don't have a lot of eosinophils. But if they gave you Bolus Pentagoid, they gave you EBA, they gave you Bolus lupus, it could be posse inflammatory or low eosinophil Bolus Pentagoid. It could be epidermolysis bullosa acquisita. It could be Bolus lupus. And if you have a subepidermal blister with a lot of neutrophils, you could think about linear IgA bolus, right? And even DH. So you have to have some clinical information or a DIF piece of data to truly hone in on the diagnosis, or they just have to give you ones that don't make sense. So the takeaway from the lecture here, the unknowns, is that you should be able to identify at least where the level of the split is and which diagnoses would actually fit with that level of split. And then given at least one additional piece of information, whether it be DIF or clinical presentation, you should be expected to make the diagnosis, or you should be expected to rule out the other ones based on inflammatory pattern. So those are some examples of vesiculobullous dermatoses and other related entities.